So next up is Mike Lee, and he's going to discuss insights in measuring cervical stenosis.
So measuring cervical stenosis, so we all know that cervical stenosis and myelopathy usually run hand in hand, but it is possible to have cervical stenosis in the absence of myelopathy, and it's also possible to have myelopathy symptoms in the absence of cervical stenosis. Now, this talk will focus on measurement techniques for cervical stenosis, and I'll discuss the significance of these measurements. And I think this invariably leads us to a discussion of asymptomatic cervical stenosis, which has been discussed numerous times on the national scene. So we all tend to think of it as a minimal full canal diameter for normal being about 13 millimeters. 10 millimeters for the cord, 1 millimeter for the dura in front, 1 millimeter for the dura in back, and 1 millimeter for the CSF. Edwards and LaRocca in Spine 1983 evaluated a series of patients. They found that people with a 17 millimeter canal were asymptomatic, and those less than 10 millimeters were myelopathic, with a spectrum in between. The problem with direct measurements and an absolute cutoff is that it has to be interpreted somewhat cautiously. We know from cadaveric studies that there are significant differences between men and women regarding canal diameters. So, for example, a 13 millimeter canal for a woman might be quite spacious, where it might be a little more tight for a man. Some studies have suggested no differences between Caucasian and the African American population, while other studies have suggested that Caucasians have a significantly larger canal than the Asian population. In addition, all these studies were done on X-rays, which is a great tool and it's been frequently used, but X-ray is just a shadow of a picture, and the dimensions of the shadow are really dependent upon the distance from the beam to the patient, the distance from the beam to the film, and the distance from the patient to the film. We know from templating hip and knee replacement surgeries, we can get X-ray magnification on the order of 10 to 25%. That may not sound like a lot, but if we're really looking at where a difference of 2 millimeters can be significant, well, we may want to question the exactitude of these numbers. So for these reasons, the Pavlov or Torg ratio was developed. We all know this to be the ratio of the canal space to the vertebral body. A ratio of 0.8 is felt to be indicative of stenosis, where a ratio of greater than 1.0 is felt to be normal. However, since that time, there have been numerous studies which have questioned the accuracy and consistency of this ratio. And I think probably, by and large, most of us use gross MRI appearance to really assess stenosis. I don't know how many of us actually whip out our rulers or may make measurements or calculate ratios. But for the most part, most of us look at the MRI appearance, looking for CSF signal anteriorly, posteriorly, any thecal displacement, or any signal change within the cord. So we all know the clinical presentation of myelopathy or clinically symptomatic stenosis. You can have any of the following symptoms. And we know that when there's correlating radiographic presentation, by and large, the treatment is surgical for the large majority of these patients. If someone has clinically symptomatic myelopathy, most of these patients are going to be recommended for a surgical decompression, plus or minus fusion, anterior versus posterior approach. The question is, what do we do when we see someone who's got relatively asymptomatic stenosis? Now, if I told you this patient had some balance problems and was constantly dropping his pen, handwriting changes, most of us would agree that this patient would probably benefit from a surgical decompression. What if I told you this patient had some numbness in his index finger and his thumb, but really no pain or no fine motor dexterity problems? Well, what do we do then? Some surgeons would recommend observation. See this guy from time to time, make sure he's not getting any worse. And some surgeons would recommend prophylactic decompression. Those who advocate prophylactic decompression will state, well, in a traumatic setting, this patient's at a much higher risk for for getting paralyzed. And this is true. A study by Kang, Figge, and Bowman in 1994 looked at 288 patients with cervical spine trauma, and they actually looked at the pre-injury canal diameters. And those with complete deficit had an average canal diameter of 10.5 millimeters, whereas those with no neurological injury had an average canal diameter of 16.1 millimeters. Advocates of prophylactic surgery will say, well, we always tell patients who have myelopathy, the primary goal of surgery is to prevent progression of your neurological deterioration. Neurological recovery, while it's ideal, is certainly variable from patient to patient, and it's never really guaranteed. So if we tell patients this, why do we wait for them to develop some sort of neurological deficit and then operate, knowing that it may or may not necessarily get better? Advocates of observation would say that, well, studies have shown that the prevalence of stenosis in the general population is about 5 to 20%. We don't really know what the prevalence of myelopathy in the general population is, but they would guess it's probably not that high. So the bottom line is we don't know how prevalent asymptomatic stenosis is. And the bottom line is we don't really know, we don't have any good natural history studies on people with asymptomatic stenosis. If we had 100 people with asymptomatic stenosis, how many of them will develop neurological symptoms in a 10-year period? We just don't know. And this discussion has also been expanded to look at asymptomatic myelomalacia, which is a little more rare. This is a patient who actually had some C6 numbness, but really no other symptoms. And there's even an argument, is this myelomalacia? We could have 3 different interpretations from a radiologist, neurosurgeon, and an orthopedic spine surgeon. So in conclusion, there are numerous measurement techniques for looking at cervical stenosis. You can directly measure it with X-ray or CT or MRI. We can use a Pavlov ratio, or just go by gross appearance. In general, we always correlate our clinical presentation with radiographic correlation. Generally recommend surgery if they have symptomatic myelopathy with radiographic correlation. And regarding the idea of asymptomatic stenosis, I think this is an area that needs further investigation and probably further discussion. Definitely needs prospective natural history studies. Thank you.
Right, next up is my colleague Virginie Hillard, who's going to talk about post-traumatic syringomyelia, pitfalls and pearls. And she's assistant professor here in the neurosurgery department at University of Washington.
I'm going to discuss post-traumatic syringomyelia. So syringomyelia, it's a Greek term for tubes or pipes and marrow, termed by Olivia D'Anger. And it was first described, the pathology, by Etienne in 1564. He called it a cystic lesion in the spinal cord that contained a fluid reddish in discoloration like the fluidity of the ventricles. And finally, in 1804, the presence of the syrinx was correlated with the clinical findings. The clinical presentation is usually a dissociated loss of sensation of pain and temperature with the preservations of proprioception and light touch. And sometimes you'll have a slow progressive motor dysfunction. And if the extension of the syrinx extends into the medulla, you'll have causing lower cranial dysfunction. It's a term called syringobulbia. Barnett tried to classify syringomyelia into 2 categories, communicating and non-communicating. Communicating indicating that there was no connections between the cysts and the 4th ventricle. And this is associated with Chiari malformations 1 and 2 and basilar arachnoiditis. The non-communicating is what the category of spinal cord trauma and post-traumatic syringomyelia would fall under. This is an example of a patient with 2 syrinx, one in the C2 and one at T2 and T3. And on the axial, you can see that the cord tissue is very thinned out around the syrinx with still evidence of subarachnoid space around it. How does the syrinx form? So a couple of theories on the pathophysiology. Williams described the suck and slosh theory, and Gardner described the water hammer theory, which are well-known sort of neurosurgical discussions for our residents. Williams thought there's a partial block of the spinal subarachnoid space causing a pressure differential between the ventricular system and the spinal subdural space. And the fluid is drawn in and it can't leave the space. And with the slosh, it can propel upward, causing a dissection and therefore enlargement of the syrinx. Gardner believed there was more of a water hammer, which I think pertains to the Chiari patients, where the hindbrain formation causes an obstruction on the outflow of the foramen of Magendie. And because of that, the pulse wave of the CSF into the opening of the obex creates an opening in the central canal. The other terms that you may use interchangeably, and I just want to clarify it, is with hydromyelia, what is that and how is it different from syringomyelia? The difference is that the hydromyelia indicates that it's an expansion of the central canal, it's a pathologic expansion, and there should be an ependymal lining in the hydromyelia versus the syringomyelia. And with the syringomyelia, you may or may not have a connection with the central canal. And of course, this comes with the 2 terms that people married together, syringohydromyelia or hydrosyringomyelia. So let's focus on post-traumatic syringomyelia. So the cavity formation within the spinal cord can occur, and it can occur very commonly after spinal cord injury. But only 3 to 10% of these syringomyelia become symptomatic. And the development of syrinx can occur at any time, as early as 2 to 3 months versus as long as 30 years after injury. There's no sex or race predilection, and although there's more male spinal cord injury patients. And here's an example of a schematic of what it would look like if you have an injury to the cord with a weight drop apparatus. And at 6 weeks, when we resection these cord, almost all of them would have some type of small cystic changes and then bigger syrinx or cystic collections. And again, one thing to notice is that it's mainly around sort of the center of the cord, which is where the periaqueductal gray matter is. So cavity formation is secondary to sometimes the liquefaction of the hematoma, the mechanical disruption. And also with all this happening, you cause an arachnoiditis or a tethering of the spinal cord to the dura, resulting in an impairment of CSF circulation. And with this impairment of CSF circulation is when you can have a CSF flow into the cavity with certain increase in pressure, such as Valsalva maneuvers, but yet they can't flow out. And so clinically, why do patients present with this dissociated pain and temperature with preservation proprioception? So in our spinal cord cross-section, here's the periaqueductal gray matter, and right along that area is the white, ventral white commissure. And these crossing fibers come from the spinothalamic tract, which is your pain and temperature mediators. And it spares this posterior column, which is your vibration and position sensation as well as light touch. If this lesion does enlarge and involve sort of this more shaded area, then you can get the other, sort of the more progressive clinical finding, which is motor weakness, because you're now involving the anterior gray horn cells. As well, if you go further laterally, you may get into the lateral cortical spinal tract, which will give you long tract signs or spasticity. And that would be the upper motor neuron symptoms that usually happens below the lesion. The morbidity of traumatic syringomyelia is associated with the weakness, the loss of function, and also pain. And mortality can occur if the syrinx increases in size and extends up into the medulla, affecting the respiratory center, or from surgical complication. The imaging studies recommended to look for syrinx would be an MRI, T1 and T2 sequences. Sometimes a GATO, well actually always I would recommend a GATO enhanced study to rule out underlying tumor as the cause. And CINI MRIs with the CSF flow dynamic can also be useful as well. CT myelogram can help delineate the cavity. And I think the important thing is you need to follow these syrinx to see if they're actually getting larger, to see if you may or may not treat these patients. So treatment options for syrinx. Again, it's only 3 to 10% of patients who have syrinx that become symptomatic. And the treatment is very controversial. There's no universal consensus of the accepted method of treatment, and there's also no universal consensus of the benefits of surgery. So the goal of surgical intervention would be, since you have this impaired CSF flow, you need to reconstruct an alternative subarachnoid pathway around the area of the adhesion where the injury site is. And so you would usually do a wide laminectomy, try to do some adhesion resection, and then communicate the cyst to the subarachnoid space. In addition, do an expansile duroplasty. To communicate the cyst to the subarachnoid space, you can do that through a direct aspiration or direct dissection into the cyst cavity, which sometimes do come to the surface, and other times you would have to do more of a midline myelotomy to access the cyst. 1955, Friedman thought that in order to really truly treat these syrinx, you need to really untether the cord, which means that if there's a deformity or bony compression or any soft tissue compression, you need to take care of those areas, because that would continue to give you these impaired CSF flow. Other surgical interventions includes a syringo-subarachnoid shunt, which can be placed to try to help maintain a flow from the cyst to the subarachnoid space. And the recommendations, these would be the pearls. You want to proceed in the caudal, at the caudal end and then direct the catheter up rostrally. You would use an intraoperative ultrasound to help make sure that the cyst has collapsed. And the expansile duroplasty is recommended to help, again, untether the cord in an indirect fashion. And if there's loculation, you may need 2 levels of decompression. The failure, however, with the shunting of these traumatic syringomyelia is very high. It goes up to 50%. And you're introducing a foreign matter. You can introduce more adhesions because you're doing more surgery in that area. And also the gradient that you need to drain from a cyst to the subarachnoid space may not last very long. Once you drain, you lose your differential, and then the shunt stops working. The effectiveness was looked at in 1993 by Askoff and Kunze, and they showed that with the syringal subarachnoid shunting, about 67 to 75% of their patients did get some neurologic improvement with a mortality rate of 1%. However, that means that about 20 to 25% of the patients can deteriorate in terms of their symptoms. And the other complications would include obstructions of the catheter, infections, and other catheter failure. I have just 2 examples of cases where you can decrease the syrinx size, but they happen to be in tumor patients that I've treated. This is a young lady with von Hippel-Lindau who had multiple hemangioblastoma, and associated with it, she had a huge cyst. So she actually presented with progressive weakness and numbness and tingling. And after surgery, removing the tumor and decompressing the cyst, in this case we had to do a pretty aggressive midline myelotomy to drain the cyst. But it can be done, and similarly with the traumatic syrinx, it also can be drained. Just another example, there's a 38-year-old male with a ependymoma and a syrinx, and this gentleman presented with symptoms of syringomyelia. And after resecting the ependymoma and draining the cyst, he did have some improvement. So, summary, post-traumatic syringomyelia is definitely seen in our practice. Up to 3 to 10% of spinal cord injury patients develop symptomatic syringomyelia. And I think the treatment is rehab, physical therapy, occupational therapy, and only on occasion will you need to do surgery. And the reasons to do surgery would be to prevent the expansion of the lesion, and sometimes with neurologic deterioration, you want to see if you can halt those deterioration. Thank you.
Thank you, Vernie, for that excellent overview. So last up in this session is Dr. Mike Failings, who's professor at University of Toronto. It's an honor to have him here. He's one of the world's premier spinal cord injury researchers, and he's going to talk to us about recovery from myelopathy. Thank you very much, Mike, for coming.
Thank you, Carlo. It's a pleasure to be here and appreciate the invitation. I'm going to talk about cervical myelopathy, which in essence one can think about as a form of a chronic spinal cord injury. And I've been asked to try to draw some inferences from a recent prospective clinical trial which we have undertaken with the Association of the AO, and to draw some parallels with regard to chronic spinal cord injury. This has been a collaborative effort. My co-authors are listed on this slide, and in fact, Seattle, Washington has been a major contributor to this study. So in terms of background, as I've indicated, CSM can be considered to be a form of non-traumatic spinal cord injury. And in fact, there are a number of synergies between CSM and spinal cord injury. The pathophysiology one can think about as involving compression. There are static as well as dynamic forces. This results in ischemia. There's a secondary cell death or apoptosis, and there's an inflammatory component. And then on the bottom is a post-mortem mid-sagittal image, just giving you a sense of some of these factors with a spondylotic bar with both dynamic and static compression. So here is some emerging evidence for apoptosis in human cervical myelopathy, and this is some work from our own unit looking at immunohistochemical and molecular analyses of a post-mortem human tissue bank. So on the top left panel, we have a patient who has classical ossification of the posterior longitudinal ligament. Panel B, we have a normal spinal cord, and panel C is actually a spinal cord of an individual who had been treated for cervical spondylotic myelopathy with a chronically atrophic cord. And what the middle panels show, CC1 is a label for oligodendrocytes, FAS is a label for a death receptor, and this is showing co-labeling here of neural cells, both neurons and oligodendrocytes, which express death receptors and which go on to have apoptosis. And this is now an example of actually translation of discoveries made from the basic science area in spinal cord injury, which has now provided insights into cervical myelopathy. And we've all seen patients who have continued to deteriorate despite surgical decompression. And sometimes the cascade of events may not be arrested by surgical decompression. This is probably one of the underlying features. And the objective of today's talk is really to provide you with some insights in terms of what are the key clinical predictors that would define outcome in the cervical myelopathy population. And then at the end of the talk, I'll try to draw some parallels in terms of how one might think about this in the context of a traumatic spinal cord injury. So patients with clinically and radiologically confirmed cervical myelopathy were enrolled into this prospective cohort study. And the patients underwent either anterior surgery, posterior surgery, or in some cases even a 360 procedure, really as defined by the operating team, using the techniques that the team was most comfortable with. So we did not dictate this at all. And then we applied multivariate techniques to examine what the impact of a variety of key metrics might be on the outcomes. And in particular, we wanted to look at outcomes using the modified JOA score, the Neck Disability Index, the NURIC score, as well as the physical and mental health domains of the SF-36. So 294 patients were enrolled in this trial, which has been completed, and we have a follow-up now in 87% of patients at a year. And you can see the proportion of patients undergoing anterior versus posterior procedures versus 360-degree procedures. So fairly representative, I think, of a typical a case mix. And I've mentioned the outcome metrics that we've looked at. So this is a bit of a busy table, but let me try and walk you through this. So what we're showing here is a distribution of anterior, posterior, and 360 cases. And on the left side are the key demographic variables and outcome variables. So there's some important differences, firstly, between the anterior and the posterior cases. Posterior patients tend to be older. They tend to have greater impairment. And then they tend to have more multi-level types of involvement, whereas patients who have anterior disease tend to have more focal involvement and tend to be younger. And so, in fact, you could see how doing a trial comparing anterior versus posterior might have some problems, because in fact the baseline variables are different. But in this kind of an analysis, we're actually able to capture this through multivariate approaches, and this was compensated for in the analysis. So the bottom line here that I'm going to show you in the next several slides is that the duration of myelopathic symptoms has a profound impact on outcomes, with 6 months probably being a key factor that does determine the outcomes. So here, this is just the distribution of the duration of symptoms in 6-month blocks. And on the left of this slide, this is kind of the take-home message, that the modified JOA, the NURIC, and the physical domain of the SF-36 are all positively impacted by the duration of symptoms. Now, patients improved in this study even if they had very long durations of myelopathy, but the degree of improvement was less. And then there were some elements of the neurological outcomes that were not as clearly impacted by the duration of symptoms. So let's just show some of the data now to back this up. So in terms of the MJOA outcome, this was impacted by symptom duration, also impacted by age, as well as the baseline status, and that makes sense. And here's the impact of the duration of symptoms. You can see a very tight linear relationship between the duration of myelopathic symptoms and the recovery on the MJOA score. Again, the NURIC, which is heavily weighted toward a lower limb ambulatory status, is also impacted by duration, similarly by age, and similarly by the baseline metrics. And here's the graph, which again shows this linear relationship. The physical domain of the SF-36 is affected very significantly by myelopathy and is also influenced in terms of the symptom duration. And here we can see that there's actually quite a steep slope to this curve in terms of the SF-36 outcomes. So the bottom line here is that the key generic and patient-specific outcomes that we've examined following decompressive surgery are all highly dependent on the chronicity of patient symptoms. I didn't specifically indicate this, but surgery, as you could have inferred, is highly significantly positive in terms of impacting beneficially on patients' outcome on all of these metrics. The best outcomes are observed in patients whose symptoms are less than 6 months in duration. However, it's never too late, and all of the patients tended to improve in the study regardless of the duration of symptoms, but certainly you start seeing a blunting of the recovery patterns. Now, just in closing then, what types of inferences can we perhaps draw from this in terms of the spinal cord injury population? Well, firstly, I've tried to show the parallels in terms of the pathophysiology and how, in fact, one can learn elements of both disorders from each other. And certainly the basic science and the clinical science has some degree of synergy. But importantly, patients with a chronic spinal cord injury, as we've heard in the previous discussion, can suffer from compression, tethering, and ischemia. And this can lead to a delayed myelopathy in about 20% of patients with spinal cord injury. So you have to really watch patients quite carefully because patients can not uncommonly deteriorate, and you have to think about this. And then as well, in terms of thinking about the rationale for decompression in spinal cord injury, one can potentially draw some inferences from the cervical myelopathy literature. Now, clearly, in cervical myelopathy, the static type of slowly progressive compression with the ischemia is going to predominate, and this is really why decompressing the cord is so effective. In the setting of spinal cord injury, the rate-limiting determinant, of course, will be the severity of the primary injury, where the secondary component, due to the compression, will vary from patient to patient. But nonetheless, there are inferences there, and if we consider the idea also of trying to prevent delayed neurological complications such as syringomyelia, neuropathic pain, and cord tethering. And what this image shows here, this is a patient who had an untreated burst fracture, managed non-operatively with not a bad outcome in terms of stability, some kyphosis. This patient was actually an Olympic athlete, a Paralympic athlete, was originally a T10 level. She actually became a C4 tetraplegic due to this huge syrinx going right up into the brainstem, secondary to cord tethering at that level. So they're quite profound impact here. And I think in this type of situation, one can see where the compressive element and the ongoing ischemia can play a significant role. So just to acknowledge our partners at AO Spine North America and all of the colleagues that have helped me with this study. Thank you very much.